Welcome, everyone. Uh, my name is Ed Stever. I'm the president of the National Foundation of Swallowing Disorders. And I'd like to welcome all of you here today, really from around the globe. The mission of the foundation is to improve the lives of all those who have a swallowing disorder. And we do that through 4 primary pillars. We provide patient support. This may be in the form of a referral to the proper medical team. It might be a support group. We provide educational information on dysphagia on our website and through programs like our dysphagia webinar series. We raise dysphagia awareness. June is just around the corner, and that is National Dysphagia Awareness Month. And we have a number of activities during June, and we promote promising translational research. Next slide, please. I would like to give a shout out to our medical advisory board. Dr. Peter Belaski is the foundation's medical director. Nancy Schwigert has been on our medical advisory board for over 5 years and has just been a rock star for the foundation. Donna Edwards joined the board in October of last year. Shuman Dar and Apurva Ramaswamy joined in the past month. And the primary responsibilities of the medical advisory board is to validate the content that we're publishing on our website. It's to help with complicated dysphagia cases and to provide a network of around the globe of referrals for patients that are looking for support in addressing a swallowing disorder. So our medical board is just outstanding, and I want to welcome the 2 new members. Donna, in addition to being a member, has been associated with the foundation for many years. She developed coloring books, dysphagia-oriented coloring books for pediatric and children, and it's now been translated into almost half a dozen foreign languages. So we couldn't do what we do without our medical advisory board. You will be muted during the presentation today. To ask a question, click on the blue question mark to type in your question, and then we'll get to as many of them as we can during the presentation. I would like to recognize and thank diagnostics through an unrestricted educational grant that has allowed us to provide these webinars free of charge. I'd also like to give a little shout out to their new product or set of products, which are Berry Bar, and they are FDA approved barium liquids that are used during modified barium swallow assessments. I'd also like to thank a new webinar sponsor, and that's Cranio Rehab. And you can get to them through the QR code on the screen. I also want to recognize that many of you donated for in attendance for this webinar, and so I want to thank each of you that did donate. We raised over $1,000, and this will all go toward a virtual swallowing support group program that we started about 4 or 5 months ago that has been immensely helpful to a relatively small group of people, but for those people, it has been terrific. We had about 1,400 people sign up for today's webinar, and this is a map of the countries where people signed up from. So we really have a nice global reach. And with that, I would like to introduce Karen Scheffler. She will be talking today about oral infection control. She's been a medical speech language pathologist for over 23 years. She is board certified in swallowing and swallowing disorders for over a decade, and has won and earned many awards during her career so far. And I've known Karen for many years through the Dysphagia Research Society. So we're really excited that Karen has volunteered her time tonight or today to share her knowledge about a subject that has gotten overwhelming response. So with that, I am going to turn this over to Karen.
Okay. Looks like I have everything all set there. I am just gonna take my camera view off there, and thank you so much, Ed, and thank you, Elizabeth, for putting this together. Thank you, Braco. Thank you for everybody that's attending and all your donations. That really means a lot. That's terrific. So what we're going to talk about today is more than oral care. It's talking about oral infection control. And feel free to share any of these slides. You can follow me on Facebook, Twitter, and Instagram. You can post from tonight. Feel free to contact me. Love to talk to you some more. All right, let's see if the slides will advance. There we go. Okay, so you heard a little bit about me from Ed, and this is just for your reference and some disclosures as well. I have nothing to financially disclose about this lecture or about the products that we discuss in this lecture. My slides are slow to advance. I'll get a hang of it. And why are we here today? Your mouth may be a cesspool of up to 10 trillion bacterial microorganisms. If you're eating dinner or breakfast, I know you're going to want to just jump up and brush your teeth right now. But fortunately, the research on how your oral health impacts your overall health is abundant as well. But you and your loved ones may not be getting such superb oral infection control like this dolphin picture here. When you're in healthcare, the oral infection control and oral hygiene programs may be severely lacking. And I love the cooperation that you see here, and even the use of electric toothbrush. It's amazing. And the evidence behind keeping a clean mouth is massive. If you know Dr. Paula Leslie, you can just hear her saying that. I wanted to put this quote in here because this was a talk that she gave at an ethics webinar, so ethics and evidence webinar. The ethical issue is just so important to highlight. And you know, through all this, of course, we are deeply concerned about the care and the comfort of people that have dysphagia, but it's the oral infection control that really has just gone under evaluated and under treated. It is a medical issue and it's an ethical issue. It's an ethical issue because we know we could be doing more in the healthcare institutions. It's even a legal issue, one of neglect, because we often are not paying attention to the mouths of people in healthcare institutions. And this is the largest open cavity we have in the human body. You can see from this picture, let me just move that out of the way there. That you can imagine all the parking spaces for microbes and the bacteria that loves to stick to plaque. Gingiva spaces and even worse, like periodontal pockets, can be up to 6 to 8 millimeters deep. So you can really just imagine all this space where you know, all that bacteria can park. I'm here in Boston. We love to talk about parking. There's always parking problems. So we're going to talk a lot about all of this nasty mouth and biofilm today, and you know, ways to prevent this plaque buildup and preventing gingivitis. Brushing, flossing, dare we say flossing? We're just trying to, in healthcare, get people to even brush our patients' teeth, but really flossing is also so important. And once you've loosened up all this debris, you also need to be rinsing and clearing things out. So niche is an important thing to point out. There may be nurses on this call or nurses that listen in the future, and it's the nurses that are the front line of defense here. And niche is nurses improving care for health system elders. They did a lot of important work, you know, over 10 years ago to promote oral health. It's associated with all these different illnesses, and poor oral health can also affect your nutritional status, your self-esteem, mental wellness, cognition even. Poor oral health is going to increase your length of stay, and it's going to cause negative outcomes that we'll be talking about today. Learning objectives, you've probably seen these already on the website. I'm not going to go through them word by word. You also, I'll take a moment to say you have all of the handouts. I provided the PDFs of the handouts in a 1 screen per page form and a 6 slide per page form. So you have all this information. This lecture is chock full of information, lots of resources. I'll be going kind of quickly, but it will be recorded and you can always listen to it again. Thank you for doing so. The categories of the webinar that I just want to walk you through for a minute. You'll see these blue boxes. The first category that we're going to talk about is introduction to dysphagia, aspiration, and why aspiration doesn't necessarily just equal pneumonia. We're going to then talk about the inspiration that we need to see to become an oral health advocate. We're going to talk about the research that's been done and even research that's still needed. We're going to talk about evaluations and then how to perform good oral decontamination and maintain this adequate oral infection control. So here's the introduction. So dysphagia is not a disease in and of itself. We know that it's a symptom of many different issues. So whether it's an acute event, diseases, disorders, structural functional abnormalities, cognitive changes, and even iatrogenic causes. I'm throwing a big word at you there. And for those of you that aren't in medicine, I will be trying to make sure that I'm speaking English as well. So iatrogenic just means that these are problems that happen because of treatments that are at the hospital. So, for example, when you're intubated, intubation can cause all sorts of subsequent problems, and that's an iatrogenic issue. Medications also have many side effects. One is dry mouth, among others. Surgeries can have other consequences that are not expected. Um, and so all of this requires a person-centered approach and a multidisciplinary or transdisciplinary approach with every patient. Dysphagia is so complex that we just really need to make sure that we're communicating across many disciplines. And so we're going to take a quick look here at aspiration. For those of you who have not seen instrumental evaluations, this is a video fluoroscopic swallow study, and we are going to get that to play there. This aspiration is happening. I'm just going to play it all the way through, and they're drinking, and then I'm going to just pause here for a minute. They're drinking mildly thick liquid. The old term is nectar thick liquid. New term, according to ITSE, is the mildly thick liquid. So in terms of going a little bit slower here, you see the barium liquid. Ed mentioned, oops, sorry, that happens when I click in the wrong spot. The barium liquid that we see coming over the tongue, spilling all the way into the throat and getting into the top of the airway here, and then the vocal cords are right here. So that liquid is just spilling through the vocal cords and into the airway along the anterior wall of the trachea here. There was no cough reaction. So sometimes we don't even know that this kind of gross aspiration is happening bedside because we're not hearing the person try and protect their airway or cough. So you can imagine if they're carrying all the bacteria-laden saliva from their mouth along with that liquid or that bolus of liquid, and that's dumping into the airway along with it, there could be a lot of bacteria heading into the lungs. Here's a look at residue, because not all the time do you just have foods or liquids pouring into the airway, but sometimes there's an efficiency problem and the food doesn't get down through the throat. There's not good squeezing of these throat muscles or good timing. There's all sorts of things that we look at. So this person is trached as well, and they may have poor sensation of this residue, which is just, compounds the safety issues. You can see then that because the residue is just sitting here and they're not able to cough because they have an open trach with no speaking valve, the material is now just falling right into the airway. So again, when this stuff sits here for a long time and it's bacteria laden, that's going to be a big safety issue down the road. But I just really want to caution people, a lot of us speech pathologists know this, that aspiration does not equal pneumonia. So it's not just a one direction, you aspirate, you boom, get pneumonia. I've talked about this at so many different lectures that I just put 2 slides together to really show how Susan Langmore's research all the way from 1998 has just changed the whole perspective for speech pathologists in our job. We're looking at much more of the whole person and all the different factors that correlate with aspiration pneumonia. The biggest thing here is to look at is this dependence. So dependence on oral care, lots of decayed teeth, lots of medications that are going to dry the mouth even further. They're also dependent for feeding. So her study in 1998, as well as her study in 2002, talked a lot about this dependence issue being bedbound. So these people are so vulnerable and they really need to have their mouth very thoroughly cleaned and with brushing the teeth to make sure that these issues don't pile up and head into a pneumonia. The recipe that I've talked about for years, I've turned Susan Langmore's research into the recipe for aspiration pneumonia. Maybe some of you are eating dinner right now and thinking about food and recipes. It shows the complexity of aspiration pneumonia. If you start altering the oral pharyngeal flora, you'll start colonizing the nasty bacteria. That's facilitated by the dependence on oral care, multiple caries, medications that cause dry mouth, and especially being NPO. So when you're not eating, your mouth can get even nastier. The act of eating is actually stripping away and clearing some of the biofilm and the bacteria in the mouth. But when you're not eating, your risk for poor oral hygiene is even higher. So with this poor oral condition, then you add some aspiration, whether it's, stuff coming up from below or saliva or food. There's lots of bacteria-laden aspirate that gets into the lungs. And that can be made worse by people who have multiple medical diagnoses, people who are dependent on others to feed them, people who have decreased alertness, they're bedbound, and even tube feeding will increase your risk of getting aspiration. So when you add those things to a host who has a decreased host resistance, so their immune system is compromised, then that really is sort of the recipe that can brew up an aspiration pneumonia. And I just wanted to also acknowledge that Susan Langmore early on started this historical collaboration of SLPs with dentistry. In 1993, this study, they started looking at this bacterial colonization of saliva and plaque in the elderly. And it was a great cooperation among the dental school and work at in Ann Arbor, Michigan. Some of their quotes were just perfect for talking about today, where we need this cooperation of physicians, dentists, oral biologists, immunologists. That's all critical. There needs to be communication between the physicians and the dentists in geriatric care. And for one example, they showed that pneumonia was confirmed, 25 to 36% in people with dry mouth or xerostomia, this inpatients and long-term care patients. So that this dry mouth is, correlated also with the risk for pneumonia. And you may be asking too, why are dentistry and medicine separate? We could go on about that too long for our talk today. So I put a little article there to take a look at. This is a big issue where we need to think about bringing these two zones of dentistry and medicine back together. And I also wanted to acknowledge Dr. John Ashford. He more recently has really been pushing this concept of the 3 pillars of pneumonia, and that's really taken off and really helped a lot of new clinicians to really understand that aspiration doesn't just equal pneumonia. So this seems very familiar to what we were just talking about, where he talked about the impaired health status. So the host resistance is down, and the stress on the system is going to cause immune status issues. And then you add to that the high prevalence of dysphagia and signs, dysphagia signs and aspiration. And for really seeing aspiration, you have to do that with an instrumental evaluation to detect those safety and efficiency issues that we talked about on the video swallow study. And then so you add the 3rd pillar is the poor oral health status. So you really have to evaluate the mouth, the tongue, the teeth, the palate, get up underneath, like look at the people's palate, because a lot of times the cleaning just happens in the front of the mouth and people aren't having the person open their mouth and really look up at the palate as well. So we're going to cover a lot of this issue today. And Dr. John Ashford also may have been the first person to really push this concept of oral infection control. People can correct me if I'm wrong, but I love this partial quotes here. This is from Swallow Your Pride podcast back in 2017 with Teresa, and thank you for Teresa for letting me share this today. So Dr. Ashford said, what I'd like for you to do is to begin thinking about oral care as not care, all right? A care is brushing someone's hair, giving them a bath, making them smell good. oral care is not that. And we have to change the way of thinking. We have to attack the mouth as though it's infected because the person is infected or they have the potential for becoming infected. So I'm really sort of pushing a revolution here today to get more into oral infection control as an ethical issue, as a medical issue, and to collaborate and advocate on this issue. Then more recently, I want to give thanks to Dr. Michael Puglia, emergency care specialist in Wisconsin. Just a couple weeks ago at our Dysphagia Research Society virtual conference, which was amazing, he shared this slide and he gave me permission to share it with you today here too. It's adapted from this research and it's this lung biogeography. So if you can imagine this pretty little island here being our lung that's in a nice homeostasis. So homeostasis is that things are balanced. And the lung, a healthy lung here is able to process things as it comes in and try and process them to clear them out. So yes, aspiration will be coming into the island. You may inhale nasty toxins. There's all sorts of things that are coming onto the island, but the lung is made to have a cough response. It's trying to have mucociliary clearance to try and clear that out. Our normal immune responses, host responses, I've been talking a lot about that. So to try and maintain that microbiome of the lung in a healthy way. But then in comes this, like I think of it as a hurricane coming into the island. So there's all sorts of factors that can make this balance really off. So if the person's always bedridden in a supine position, if the person has dysphagia, if they have a lot of reflux that's getting all the way up and into the airway, if they have poor oral health, that was a key factor that he had here. Also, if there's respiratory distress, so if there's a significant fast respiratory rate, they're not able to coordinate their breathing and their swallowing, and if they're in significant distress, they're really going to have a hard time managing this balance. So that's as things come in. Then we have to ask, how prepared is the island to deal with this? How prepared are they to clear this stuff out? Well, if the person has poor sensation and a poor cough reflex, they're not going to be clearing it out well. Or if they have an endotracheal tube in, that's the intubation that we've heard a lot about through times now with COVID. So endotracheal tube in place is going to make the clearance really hard. Any kind of airway obstruction or immunosuppression, all this. So I really like this slide. It kind of just says everything. All right, so pictures speak 1,000 words. We want to be oral care advocates, and we need to kind of understand first of all, what does a normal look like before we start looking at the pictures that help us advocate? This is a FEES study, so fiber optic endoscopic evaluation of swallowing. I'm going to turn that volume down there. This simple normal video is available even on YouTube here. So, but the key thing to see is a FEES really helps you see right down into the larynx there. I'm going to pause that. You can see how nicely pink and shiny, and the mucosa and saliva coating is nice and slippery. Boluses can just slide down. What we're looking at here, just in case you're not sure, this is the back wall of the throat, posterior pharyngeal wall. Your esophagus is right, the opening will be right there. This is the opening of your airway. So the vocal cords here, your epiglottis, with the whole mechanics of swallowing does flip down there. And then you see the liquid here is dyed green on this FEES study. And I'll just let this play a little bit. So with FEES, we can see how's the hygiene, how's it looking, how's the moisture, and what's the structural or functional issues in there that's causing the trouble swallowing. FEES can also do sensation testing, which is critical to know if sensation is a factor in swallowing. And I'm going to go to the next one. This picture, courtesy of Dr. Jamie Fisher from Western Kentucky University. And so this is the same, we're looking at the same thing, supposedly. What we have here is that same image that you're looking at on the FEES camera. However, look at all of this biofilm, dry sputum, all this stuff. This is the posterior pharyngeal wall, a very narrowed airway. This can be an airway obstructing phenomena. So in addition to the aspiration pneumonia that we're talking about, this can actually be a choking and asphyxiation risk as well. You can see that this is the uvula hanging down. The back wall of the tongue base here is coated white. When we see coatings of white in the tongue base or just with our oral exam, we don't diagnose thrush, but we certainly want to describe that to the medical team that things are coated white and other symptoms, so that that thrush can be appropriately diagnosed and treated by the medical team. So biofilm, we've started talking about a little bit. You can see as you get into the hospital, biofilm can start forming very quickly if you don't have adequate oral hygiene. Here by 13 hours, you have a thick, dense biofilm. And so then how's the saliva? The saliva has immune properties to it, but how's the saliva supposed to do its work if the whole mouth is just coated in a biofilm? And so here's the effects of poor oral infection control practices. I'm going to play this one here. You can see all this material here that the person had not been able to clear. And this is the key thing right here is some of this material or biofilm or phlegm that's dried up in there can really stick to the walls. Other times it's partially adhering and can fall into the airway. So they're trying to have this person, sorry, there we go. They're trying to have this person cough and clear, and they're just unable to. And it's just, very coated. You're not able to give this person any oral intake because this is just far too dangerous. So the cough is doing nothing to mobilize that big chunk there. And this is the same patient after 12 hours. Get the volume off. After 12 hours of some nice humidification as well as good oral decontamination practices, things are looking a lot better and they are just a little bit stringy. But now the person's able to have oral trials. We can start feeding them or starts, the evaluation of these oral trials. And yes, your documentation needs to be brutally clear. We have to advocate for our patients. And when you're pulling things like this out of their palate, out of their mouth, off their tongue, sometimes their tongue is adhered to the roof of their mouth. It's so bad. I've had doctors say, don't show me that. And I'm like, you need to see this. This is really part of why they have fevers, why they have infection. They may be looking all over the body to figure out what's wrong with the patient. It's like, just look in the mouth and look at how bad it's gotten. So we need to, measure these things and implement changes. And also, get help. If you see this in the mouth, you're not just going to yank it out. You got to be careful for bleeding risks. You have to be careful to extract it carefully to not cause any choking. Okay, so into the research. Our healthy microbiome, we've talked about this concept of our lung microbiome, but our ecosystem of our mouth as well has normal flora. It's made up of mainly gram-positive bacteria, which preserve our homeostasis. So again, that term homeostasis is this balance that your body is trying to maintain. And so this healthy flora, they occupy receptor sites in the mouth to try and prevent the gram-negative bacteria from sticking. They ingest nutrients and starve out any invading gram-negative bacilli. They ward off the bad bacteria, and they continue the normal physiological process of shedding and mucosal cell renewal to help clear out bad bacteria. Part of eating and swallowing, you're stripping that and shedding that as well, and it maintains a healthy balance. And believe it or not, everything I'm talking about today is not new, but it's amazing how long it has taken, 50 years of research about this topic, to start really seriously trying to change oral health in healthcare. In 1969, this study was really the first study talking about this sort of 3 pillars of aspiration pneumonia, because they were talking about changing pharyngeal bacterial flora of hospitalized patients, the emergence of gram-negative bacilli. They discussed the presence of gram-negative bacteria in people who are hospitalized and critically ill. So when they're critically ill and in stress, this biofilm of gram-negative bacteria builds up quickly. So with higher severity of illness, they have worse pharyngeal clearance of this pathogenic pharyngeal flora. Then when these individuals aspirate, they carry that bacteria from the pharynx and the mouth into the lungs. And so back in 1969, this may represent an important initial step in the pathogenesis of pneumonia due to the gram-negative bacteria. And this is also, kind of further discussed by Scarrett in 1989. They talked in that one, I like the term that they use of a road to pneumonia. And they were talking a lot about how the epithelial cells of the mouth and the pharynx actually are altered to have greater receptivity for the bacteria adherence. So these concepts are not new. That's a key thing to know. I've loved this study for so many years, from 1975. We have to know our history, don't we? So 1975, they were talking already about the triple threat of aspiration pneumonia. So there's 3 distinct aspiration syndromes. We can't just think of aspiration in this silo of just aspiration pneumonia, as one thing. It's many different things. And it's best categorized by the nature of the inoculum, or the nature of what gets into the lungs. Aspiration of toxic fluids could be reflux or vomitus. You could aspirate objects, substances. The key for us here is what he described as aspiration of pathogenic bacteria. The aspirated inoculum is composed largely of oral pharyngeal secretions, especially saliva containing bacteria pooled from the tongue, gingiva, buccal mucosa, and pharynx. So the decisive factor among patients who develop pulmonary complications is presumably related to the frequency. So how often are they aspirating? How much are they aspirating? And the character of the aspirate. What's in the aspirate? Is it just clear water with a clean mouth, or is it nasty mouth and all sorts of stuff? So when we jump forward to 2020, I was, struck by Kendria Garand, this wonderful summary article of, kind of what we need to think of as speech language pathologists when we're looking at somebody for dysphagia. And it's amazing how after 50 years of this research, we do still have to remind healthcare providers to provide oral care before giving any oral trials. So they say, routine oral care is crucial for all patients, not just the ones that are eating, but especially for the ones who aren't eating, the ones who are NPO. Is crucial for all patients, not just stroke patients, not just dementia patients, but all patients at the hospital or in the healthcare institution, or even patients at home, people at home. And so why? They mentioned the patient comfort, and then they also mentioned to reduce the pulmonary complications resulting from aspirated material. They cited lots of the great studies that we've already started talking about, and we'll talk about some more. And I think people just sort of got stuck on this concept of that oral care is for comfort only, and we really need to move on from that into the oral infection control. So reducing pneumonia in nursing facilities, this was a seminal study in 2002, and I'm old enough to remember how it really just changed our whole life as speech pathologists in healthcare. Fabulous study out of Japan, large study, randomized control trial. The one group had good oral care with trained caregivers cleaning the mouth with a toothbrush after each meal. The iodine as needed. The key here, they also had dental hygienists once a week. So bringing dentistry back into healthcare and having some professional cleaning happening is crucial. So the pneumonia, febrile days, death from pneumonia decreased significantly in that oral care group. And you can see the percentages here. So pneumonia percentages, mortality from pneumonia, 7% in the oral care group versus 16 in the non-oral care group. Of course, the non-oral care group was just sort of business as usual. And a key point too from the study was that even older patients, or sorry, even older edentulous patients had similar reduced rates of fever, pneumonia, and death from pneumonia. A lot of times people think that it's just people with teeth that are really going to benefit, but people who don't have any teeth or edentulous are benefiting massively as well. And so Ortega's work here was frequently cited also by Dr. John Ashford that I mentioned earlier. This study in 2015, he looked at frailty, oral pharyngeal dysphagia, and oral health. So looking at these individuals who were frail and had oral pharyngeal dysphagia, grouping those who had acute pneumonia, prior pneumonias, and without pneumonia, and compared them to the older controls. Oral health was poor in all groups, with periodontitis. Bacterial load was higher in the oral pharynx than the nose. With COVID, we think so much about the nose and the nasopharynx, but with oral pharyngeal, bacterial load, this is where we're thinking now. So the colonized, there were 5 respiratory pathogens colonized, 88 to 93% in these pneumonia groups versus only 67% in the controls. I do have in the slides lots of my blogs from the swallowstudy.com. I have, if you're missing traveling, take a trip to the lungs with 12 microorganisms. I have lots of sort of joke, pun-like travel blogs about oral hygiene. So this one, reducing pneumonia in stroke, Sorensen and colleagues in 2013 showed how intensified oral hygiene programs plus early identification of dysphagia in people with acute stroke reduced the aspiration pneumonia. And so the intervention group had pneumonia at 7% only, versus an internal control had 28%, an external control from a similar type of hospital had 27%. Gram-negative bacteria is common in hospitalized people with acute stroke per this article as well. And then also Mary Lyons and colleagues in the UK, they did an article just titled "Oral Care After Stroke, Where Are We Now?" And I wanted to point this out because they have a nice supplement in their publication to show you what each country has said or done about their stroke guidelines. So that's an interesting chart to take a look at. Ventilator-acquired pneumonia is VAP. And this research really blew me away because this research was done with just a toothbrush. There was no mouthwash added. There was no chlorhexidine mouthwash added. There was no iodine added. There was no toothpaste added. This was just the use of a toothbrush, just the friction and debriding action of a toothbrush. So they randomized people 7 days of just toothbrushing with purified water versus 7 days of the typical usual care with just swabs. So the vast difference of 17% ventilator-acquired pneumonia versus 71% of the VAP. This toothbrushing group also had better oral health and better plaque index scores. So we know that just swabbing, this usual care, is just not working. Toothettes are wimpy. Toothet sponges are wimpy. This was a dentist that I had communicated with years ago and had seen a lecture, 2014, I believe was. And we need that toothbrush. We have to remove plaque. We have to get that plaque and the tough stuff out of there before the plaque becomes what's called calculus. And we'll look at pictures of that in a minute. And lemon glycerin swabs can do more harm than good. We have to take a side note on lemon glycerin swabs here. Research since the 1960s has concluded that they're not beneficial for oral cleaning and may be harmful. Unfortunately, there's a lot of sort of reviews out there longer ago that said, oh, this is nice for care and comfort, but it's not helpful for oral cleaning or for oral hygiene. This is just one nice review article here that was saying how to manage people's thirst in the ICU. And they cited 5 articles discussing the following negative effects of lemon glycerin swabs. The citric acid that is in the lemon glycerin swabs may have a pH as low as 2. It dries and irritates the oral tissue, and it can cause irreversible enamel softening and erosion. You soften that enamel, you're going to just stick more bacteria to it, and that's per this study here. Over time, it can lead to increased dry mouth or xerostomia as well. And when we look at non-ventilator dependent adults, so we talked about people who are on ventilators and how there's a lot of research out there about preventing ventilator-acquired pneumonia. But it can also, good oral care, good oral infection control can also help people who are non-ventilator dependent. These Kanoka and colleagues including Dr. Langmore and Luis Riquelme from New York City, and others, performed a meta-analysis of many articles. Unfortunately, only 5 met inclusion criteria. They were looking at the relative risk of pneumonia as well as mortality. When they pooled these subjects together, the 2 studies that were looking at chlorhexidine were not strong studies to pull out more meta-analysis information from, but the 3 studies were on mechanical teeth brushing itself. They were strong studies, I think all out of Japan, the one that we mentioned already and others, and they were showing how the teeth brushing plus this professional oral care was really the best combination. So there was a significant risk reduction with these oral interventions, but it's the combination of advanced mechanical cleaning, brushing the teeth, plus the occasional professional oral care that helped reduce the relative risk for pneumonia and reduce the risk of dying from pneumonia. It was consistent with other systematic reviews, and they concluded that to really help these nursing facilities to provide life-saving care for such a fragile population. And so again, reducing pneumonia for institutionalized elderly was also looked at by Pace and McCullough in 2010 in this review of articles, looking at associations of oral microorganisms and aspiration pneumonia. There is a correlation between poor oral hygiene and respiratory pathogens. Respiratory complications decrease when people receive either chemical, meaning like the mouthwashes. There's also some studies that look at the antibiotic pastes for the mouth as well. Those are the chemical interventions or mechanical interventions to improve oral health. But there's certainly more research needed on specific protocols for skilled nursing facilities and other places to reduce aspiration pneumonia. This HCAP is healthcare acquired pneumonia. Some people call it a hospital acquired pneumonia as well. And reducing pneumonia for people who are tube fed is a crucial thing. Mayada and Akagi, I think also from Japan, 2014, they looked at people in long-term care who were bedridden and NPO on tube feeding. It was an observational study, not a randomized control design, but they observed people for over 4,000 days. They had an oral care protocol group where they were brushing teeth 2 times a day, teeth and tongue and mucosa. They were swabbing with the chlorhexidine, moisturizing mouth, and even providing salivary gland massage. I like that. Whereas usual care, this is what happens in healthcare. Most subjects received oral care 1 to 0 times a day. There was no standardized procedure, and oral care with a sponge was done, and they moisturized the mouth if they noticed it to be dirty. That's the way it was described. So we really saw that the rates of all these things were lower in that oral care protocol group. So less pneumonia, less fever, less antibiotics administered, less need for blood tests and radiology exams. So think of, not only the health and quality of life and wellness that you're achieving here, but also to help buy in with your administrators. It's the 41% decrease in hospital costs when an oral care protocol is used. And so oral health in people with dementia is another huge area. Foley and colleagues in 2017, colleagues including Dr. Rebecca Afu, if you are on Twitter, definitely follow her. We've been chatting about this over the last couple of weeks as well. And they performed a meta-analysis of 28 studies comparing people with to without dementia. And this is across the disease severity, not just very severe patients, and then also across living environments, home as well as in healthcare institutions. So the people with dementia consistently had significantly fewer teeth, more cavities, more decayed surfaces, worse oral health, worse oral hygiene, periodontal health, denture fit, and worse health-related quality of life. And certainly this is related to a lack of oral infection control protocols, but it's also in this population related to the cognitive or behavioral declines, refusals, maybe much more dependency, a lack of salivary flow, the use of medications that cause dry mouth, and a baseline even of poor oral health. And you can see these other studies here. As Dr. Afu and I were talking more about it, one of the main takeaways that she was saying was the main takeaway is that poor oral health is absolutely an issue for individuals with dementia, but I don't think the relationship is clearly unidirectional. And this is what we've been talking about throughout the webinar, where it's not just, those people with aspiration will automatically, those people who aspirate and have poor oral health will automatically get pneumonia, but we want to look at all the different multifactorial issues that go in it. And so some of these multifactorial issues, like we said, reduced salivary secretion. The saliva is so important to maintain good homeostasis in the mouth. Reduced independence to perform their own oral hygiene, increased oral residue after they're eating that might sit there and pocket and contribute to cavity development. And that baseline of poor oral health is certainly something to look at. Dr. Afu was saying how there's some evidence to show that periodontal disease may be linked to the development of the development of Alzheimer's disease. And poor oral health also impacts food acceptance. There's a lot of issues that us as speech pathologists need to look at when we're evaluating a person. Are they in pain? Is that why they're pressing their mouth shut and don't want anything? Do they have this dysgeusia, which is this altered taste? So if you have poor oral health, and even some medications can alter your taste. Poor oral health could cause, certainly teeth loss and mastication issues. It's going to affect phases of the swallowing all the way down. If you're not chewing things well and adding saliva to that ball of food, that's not going to slide through your esophagus very well either. So it's all phases of swallowing and certainly across quality of life. So a research summary here, oral infection control can reduce the incidence of the pneumonia. And so you're reducing preventable harm. You're decreasing the length of stay, you're improving patient comfort and safety, and maybe even with thorough oral infection control, you can provide some water between meals after good oral decontamination. I love this from Twitter, at a geriatric conference. They asked people, what's the one thing I can do to improve your hospital stay? And you see water just sitting right out there. So cleaning people's mouth can really also maybe foster having them get some water between the meals. Okay, so what we're going to do now, taking a little bit of a breather, you can start thinking about a few burning questions. We're just going to stop for a few questions. I just want to make sure that everybody's kind of with me before I get into evaluation and treatment. And then also Elizabeth is going to start 2 polls. And so this will just take a few minutes here. I will let Elizabeth pull up those polls.
We can do the polls here one at a time, Karen. I'm going to launch the first one.
Great.
All right. And while we do that, while I wait, I'll read you one of the questions here.
Okay.
Nope, it's actually not letting me read the questions while the poll is running. But
we didn't know if we'd be able to squeeze that multitask in there.
That's like Lance said. There was one question about performing oral cares in people with dementia, and sometimes they have behavioral concerns that make it challenging to do that. Absolutely. Do you have any tips or suggestions?
Yeah, just a couple comments with that. The one is you want to try and make it as automatic as possible. Bringing back the automaticity can help. So, and electric toothbrushes are also going to be so important for anybody who has mobility issues. The action of bringing those little hospital toothbrushes up there might be harder, but if you put the electric toothbrush in their hand, kind of hand over hand, support that elbow, get their mouth or the hand right up to the mouth, and help them, just realize this is a toothbrush, and it's a pretty automatic task that we've done all our lives. So you're hoping that sort of sensory input of you having them hold it is going to trigger them realizing, oh, I just have to open my mouth and brush here. If you have a toothbrush, like electric toothbrush that's not on suction, you may also need to have handy a yank or suction and oral suction to get the stuff out of there. I've worked with dementia for over 20 years with people with dementia, and I understand there's many people who actually just, no matter what you try, as gentle as you are trying to be, there's many people who are just clamping and refusing. And so the other thing with dementia is we have to think about, you know, quality of life, and that we have to think about the goals of care, that maybe if they're getting very much into the severe stages of dementia, it's time to start thinking about a goals of care conversation, and maybe shifting towards a more palliative care approach. You know, dementia unfortunately is a terminal illness, and this is, you know, the aspiration, getting aspiration pneumonia is unfortunately what causes the demise of people who have end stage dementia. So it does require some collaboration as well with palliative care team, with, you know, hospice even. And you know, hospice can do a lot also to help comfort. The nurses through hospice have amazing ways to help the comfort for our patients. So okay, and so Elizabeth, I'm not seeing the poll results. Do I have to pop my screen open here? Let's see here. Oh, there we go.
Might.
Yep.
I think people can see it. Do you see the
Good.
results?
So yeah. So that's great. So the first one that we have there, you know, asking, do you feel like the people that you work with are getting good oral care, good oral infection control? Only 4% believe that they're individuals that they work with. So that's a lot of advocating to do, and thank you for being honest on that. And there's a lot of work to do out there. I knew that was gonna be the case. So then the next question is
Yes,
that
let
one.
me, here,
Yep.
I'm gonna launch that one. And while people respond, I'll ask you another question.
There we go.
There's
Okay.
a question about how to perform oral cares in patients that are intubated.
Yeah, so another good question. So you can, you know, work around the oral is, you know, the intubation tube. It's usually coming in from one side. You really want to also protect their lips of where that's all coming in. Of course, with people with COVID, they have also been, you know, having a lot of trouble, whether, you know, maybe they're in a prone position, and that's going to be really challenging. So there are a lot of challenges, but you can get in there. And the key also, what we're going to talk about in the next section, are these kits that are suction toothbrushes. So if you have the toothbrush in there to kind of get the debridement happening, it's on suction, so it's starting to take out the debris and get it out of the way. So cleaning and then moisturizing and protecting that fragile mucosa when that tube is in place is so important.
All right, I'm going to close the poll here, and then I'll share the results with you.
Yeah.
You should be able to see them on your screen.
Do you want to read that full question there for people again?
Yes, absolutely. So the question was, in our healthcare facility, we have an oral hygiene or oral infection control policy and guidelines in place. And so you'll see on your screen, 11% of the respondents said
11.
true.
Right. So this is why we're here today. This is that's really amazing. And so partially true, 29%, totally false is 33%. So yeah, so it's time to really collaborate. I hope maybe out of this that we can start the revolution of collaboration among dentistry within medicine as well. That's just so crucial. Okay, well, thank you so much. And I'm gonna slide on here to the next topic there. And this is kind of what we started talking about here anyway. So how do we evaluate a person's oral condition? And then the next topic is going to be, how do we treat? So of course, Ortega and colleagues, again, in another study, they said, we recommend a policy. This is why I asked that question, a policy of systematic oral health assessment in elderly patients with oral pharyngeal dysphagia. So you do need policies and guidelines in place that are multidisciplinary. And here's that calculus that I promised you that we were going to talk about. And I just had to make the stupid joke of not that kind of calculus if you're thinking of high school math. But you still need to worry about calculus. when you, as a speech pathologist, as a nurse, as anybody in healthcare, is evaluating the person's mouth, you know, you're opening up the person's mouth, you've got your tongue depressor, you got to have a good light in there, and you're looking at the surfaces of their teeth. So my son just recently got his permanent retainer removed from phase 1 of his orthodontia. He's now just got braces of phase 2. But so when he got this permanent ring of a lower retainer in there, when he got it removed, it was in there for a year or more. You know, he comes back and he's like, look, my retainer's gone. I'm like, you need to go back to the dentist and have them remove that, because of course he was at the orthodontist. So then we had to make an appointment with the dentist before the braces got in there and in the way, to have all this calculus removed. So this calculus, what happens is when we don't do good oral hygiene in the hospital, that biofilm plaques on, so all the plaque sticks onto the teeth. Bacteria loves that plaque, so it sticks on even more. The plaque just builds up and builds up. And if we don't brush that off, you have to brush. You can't use the little swabs, they do nothing. You have to brush and debride that plaque off. If you don't, it turns into calculus. And you will never get this off with any kind of toothbrush. You have to go see the dentist. And this is why we have to bring the dentists back into healthcare. They have to help us get this out of here so that you don't end up with periodontitis and deep periodontal pockets that could be, you know, 8 millimeters deep, really harboring or parking our bacteria. I just want to make a quick blurb about screening for head and neck cancer. You know, because our patients are not, you know, if the people that we see are in nursing facilities, hospitals for a long time, they often are like, oh, I just missed my dentist appointment. I haven't been to the dentist in years. So who's doing that really thorough head and neck cancer checks that our dentist does for us? So as speech pathologists, when we're evaluating the mouth, these are also things that we need to look for. We need to raise the red flag on any kind of sores. We need to look at their palate, any kind of changes in color, sores, bumps, anywhere. We need to listen to their voice. If you hear that hoarseness or especially that harsh vocal quality, if you hear changes in nasality, and certainly if you see issues on your video swallows and fees, you're referring those immediately. Also bedside, sometimes people are complaining of pain with swallowing, and sometimes if there's a head and neck cancer issue, they can have pain radiating up to the ear. So all those symptoms, we need to be raising the red flags. So in terms of oral health assessment tools, this is the main one out there. Chalmers et al. In 2005 modified the Kaiser-Jones exam, and the OHAT is the most common one that's out there. I want to show it to you in a revised form. Chalmers revised it again, and I like the color coding here a lot. You can see the 0 for all the healthy, normal, pink, moist, beautiful side. But then as it's changing, some of these issues might just mean you need to do some intervention. So yes, dry, chapped, irritated lips, number 1 means you need to intervene. So what did you use on the lips? How did you take care of that? Whereas the 2s or the pink areas here all mean that you need to refer. So for example, natural teeth, 1 to 3 decayed or broken teeth, or if there's a lot more broken teeth, 1 or 2 both need referrals. So it really guides the nurse quickly into how to either just intervene or do a full referral. And the form as well, you're marking down what the interventions you did and who you referred to. And so speech pathologists can use this, CNAs, nurses, all sorts. This was made for non-dental professionals. And then here at the Beth Israel Deaconess Medical Center, which is where I am now speaking to you live from Thursday evening, we had in 2016 had started this oral care assessment tool. So rather than OHAT, it was the OCAT, and looking at lips, tongue, gum, palate, teeth, saliva secretions, and swallow function. It classified people into 3 categories of like no major problem. Let's just continue with the usual care, which should be a toothbrush 2 times a day, or let's ramp it up to a mild dysfunction or moderate to severe dysfunction. And it guided the workers on how to provide the oral care. And so to take a look at this a little bit here, the lips, tongue, gums, and palate. So you're looking for that pink and moist and intact, versus slightly off, versus swollen and red, versus extremely dry, thick, engorged, coated, caked. So when I was talking to my colleague, Cynthia Wagner, who I believe is on the call and may be able to pop into the chat if there's questions about this BIDMC. She was the lead author at the time of this study. So Cynthia was saying how easy this became for nurses right from the beginning. They so quickly, could look in the mouth with their tongue depressor and light and just, put people in these categories pretty quickly. With saliva, it's easy to know if, or is there, mildly increased secretions, or are they drooling? Do they sound gurgly? But it clears with a cough or suction. Or this is the big thing, where if they have copious secretions requiring suctioning, still wet after suctioning, these are the people that we're really worried about carrying that saliva down into the lungs. And then the swallow section of this is, of course, subjective. But are they already on a modified diet? Do we already know that they have some aspiration risk from our instrumental exams that we did? Are they NPO or have a really significant aspiration risk, or are they really unable to swallow and with severe aspiration risk? And to look at the rating score, then you can see this was a 4-point scale, so out of 16. The scores of 4 to 5 could be that they're fine and you use that toothbrush. Score 5 to 8 is a mild alteration and you're following a little bit more strict guidelines, and we'll look at the times per day in a minute. The moderate to severe score of 8 to 16, and really ramping up the amounts. And especially where they ramp up is here, where moderate to severe, Q4 hours. So you're getting oral care 6 times a day, and you're picking the right pack. There's these are the SAGE oral care kits, and it's helping nurses guide to which pack is needed. So so this is a Q6 hours, which just means every 6 hours, and this is Q4 hours. And so the great thing about this is that when everything's normal and things are looking good, it doesn't mean you can just be like, usual care. It means use the toothbrush 2 times a day. That should be usual care. And so OCAT research, as I mentioned, Cynthia Wagner and colleagues here at BIDMC in 2016, they showed the reduced risk of stroke-associated pneumonia by improving the evaluation and treatment of oral health with the OCAT, and then providing the appropriate Q4 to Q6 hour treatments. Pre-program, it was 14% that had developed a hospital-acquired pneumonia, and then the group post-program, it was only 10% that developed a hospital-acquired pneumonia. So this showed that a large hospital-based cohort of people with acute stroke could benefit from a decreased odds of developing aspiration pneumonia. And we also want to think about quality of life. So as the speech pathologists know here on the call, we have things like the EAT-10, Peter Belowski, which of course, him being the medical director of NFOSD, we got to give him a shout out there. So the EAT-10 was created by Belowski and team, and it helps us evaluate the quality of life or the handicap, the health impact on swallowing, but we often don't think about what's your health impact of your condition of your oral cavity. So this it used to be, the OHIP used to be 49 questions. The researchers narrowed it down to 14 questions, and it's a 5-point scale. It's available in many languages that I found in terms of researching this, and it's across many different domains. The next slide just shows the 14 questions there. For example, has your diet been unsatisfactory because of problems with your teeth, mouth, or dentures? Okay, and so now we're on to the treatment and making lasting changes and maintaining that healthy oral microbiome. So what can alter your healthy microbiome and what alters its attempt to maintain homeostasis? There are so many things that are attacking the system and affecting it. So poor oral infection control, poor baseline oral health as they come into the institution, and then the critical illness and the stress that people have from being acutely ill really can alter the flora and alter the pH of your mouth. I do have some blogs about that as well. It can alter the saliva chemistry and everything, and we'll talk about that in a minute. Medications, dry mouth sores, infection, limited mobility, NPO status, the overuse of antibiotics, and maybe even the overuse of some chemical decontamination methods like the antibiotics or the antimicrobial mouthwashes that are real heavy duty. And we'll talk about that in a moment. So let's take a step back a minute and talk about saliva. I do have several blogs about saliva, and Nicole Rogas-Puglia is she's cited here in a minute. We've talked about saliva quite a bit over the years, and she wrote a blog for me as well. So thinking about saliva, it does so many things for us that we really take for granted. The digestive process begins. It helps with taste, it lubricates, certainly for talking all this time, having some saliva in the mouth, lubricating the oral cavity for speech. And the key here, the antiviral, antibacterial, and antifungal properties of saliva, just can't be overstated. So the cleansing properties as well of saliva, it protects and repairs mucosa. It helps with dental remineralization. So we talked a little bit there about how the saliva, the pH of saliva should be balanced at about a 6, but low salivary flow and the stress of illness can really start altering the saliva pH, and the study found that the low salivary flow can drop it to an average of 5.3, which is on the acidic side. And then you add to that acidic foods, and believe it or not, the bacteria that's sitting there in the mouth has byproducts of waste, which are also acidic. So if I haven't grossed you out before, I may have now. And then caries prevention. So the saliva, if the saliva becomes more acidic, as we say, it can harm that tooth enamel, cause decay, and have more caries. It shelters microorganisms. Within hours of birth, you start developing your early microbiome community, and then into adulthood, you're really reaching that homeostasis. The buffering capacity of saliva, it prevents bacterial colonization, that adherence to the saliva, like we talked about with that Scarrett article a ways back. And it manages the thickness of the biofilm, the amount of bacteria in there. It maintains salivary pH and neutralizes acids. So here's, again, if you miss traveling, this was years ago, I went to Mount St. Helens and I compared what happened after a volcano erupts, what happened to the ecosystems biome to what happens when somebody is critically ill and in the ICU, what happens to their human biome. It's, things get thrown out of whack pretty easily. And then here's the saliva article from Nicole Rogas-Puglia and her colleague. And so what we need is complete comprehensive oral infection control. Oral infection control kits ensure 24 hours. It has a kit that just guides the nurse through the hours of how to do targeted cleaning, debriding, rinsing, suctioning, and moisturizing. Because if we think about it, we can't just be in there brushing with a normal toothbrush because we're actually loosening up a lot of debris, a lot of bacteria and things are getting loosened up. And then what do? You've got to rinse it out. You've got to clear it out. So these suction toothbrush kits, they have the suction toothbrush as well as the suction swab. So then you can come in here with lots of mouth rinsing solutions on your swab and really get all the bacteria out that's been loosened up. And then you've got to come in and moisturize. And this is just one of the products out there. The other product is Medline. So these are the two brands. Again, I have no financial disclosures here. The nice thing, they both guide staff through exactly what to do. This one is, you can see 2 hours. Then this one's every 4 hours. They have an every 6-hour one. The Medline does have a guided box like this for pediatrics as well. Having access to pediatric suction toothbrushes is so crucial as well. You know, this talk is geared towards adults, but I did have an early question that NFOSD sent to me from a speech pathologist colleague out there asking about, you know, what should we do about pediatric oral health? And it's absolutely just as important in our hospitals and in, you know, even if the child's at home with a G-tube, a trach patient, you know, these kids are at home and the families absolutely need the right equipment. When I mentioned, you know, the niche that nursing for healthcare organization, their barriers were that nurses either don't have the knowledge, but you know, a lot of them have the knowledge, but the main barrier is they don't have the tools. And then maybe their routines are so busy, the hospital routine is so busy, but we have to provide the right tools, whether it's at home or in the hospital, and we have to provide the right staffing to make sure this all happens. And so with these kits that we're talking about, the patients are safer with these kits. The toothbrushes are very soft, which is very important. You know, as you're starting to brush people's teeth that haven't been brushed in ages, you might get some bleeding. A little bit of bleeding is okay and expected. You do want to look at their platelet level and be careful and be gentle. But it's really important to have toothbrushes that are soft. Also for infection control in general, and with COVID, it's important that these kits, you know, it's individually wrapped and they're changed often, and that the suction is connected right to the suction toothbrushes. The kits hang right in the room. They're so convenient. So we're taking away that barrier of like, I don't have the tool, or, you know, oh my gosh, I'm in the patient's room and I don't have the right cleaning materials. Ideally, these kits are hung in the room every morning, and you've just got, you know, every hour guided for you there. It's a visual reminder as well. So people report feeling more comfortable asking for water less often, which is good if they do need to remain NPO. And then with, you know, routine completion, with really staying on top of it, you'll find that you know, much less time is needed and the frequency of control may decrease over time. You may be able to go from every 2 hours to every 4 or 6 hours. And don't forget to moisturize the entire mouth. One thing we often recommend in the ICU, especially, you know, because maybe they're on high flow oxygen, maybe they're on BiPAP mask overnight, blowing tons of air into their mouth and down into their nasopharynx. They need humidification. And even if there's no oxygen requirements needed, you can just do like a shovel mask sitting on the patient there with humidified air. People who can't tolerate the shovel mask sitting there, we have rigged up things to you know, the side of the bed, you know, just sort of almost like you're getting a facial, like rig up a tube blowing at the patient, you know, at least a couple hours a day to give them humidified air. And then you just really want to keep that mucosa moist, especially for patients who are mouth breathers. And then there's moisture products. There's the moisture packet in the Sage. There's also other products like Biotene. Xylem melts are pretty cool. There's these little wafers that can just stick, you know, to the roof of your mouth or up to the gum, and they provide some, you know, maybe an hour or so of some more lasting moisture. Some people like mouth coat. A key thing with saliva substitutes is just try a lot of them. I've had some people that I've worked with where they try one and, oh, I don't like the minty flavor, that's horrible, but just keep trying different ones until you find one that you like, because everybody's going to be different with that preference. And really make sure that you get the moisture all around the mouth and swish and swallow it to coat the throat if they can. Saliva substitutes have been shown to reduce the perceived effort of swallowing and reduce dysphagia symptoms. Here's Nicole Rogospuglia and team again. They did this study with healthy adults, but showed that, that it did help in the perceived effort of swallowing. This study also was in head and neck cancer survivors. And again, there's that article from Nicole Rogospuglia and her student at the time, Joanne Yee. And don't forget about the lips either, especially with our intubated patients or people maybe after a stroke that might be drooling out one side more so, or people who have dry mouth. You can really get these very cracked lip that just looks so uncomfortable. And to know too that there are issues that can be maybe more severe than just, oh, my lips are dry. This angular cheilitis is pronounced, is an inflammation of the lips. This particular one can be caused by fungal, like candida, like a yeast, or a bacterial infection. It can be caused by allergies. You know, so we really have to refer to get appropriate treatment for the mucosa that we see changed. And don't forget about the dentures, because dentures never look this good. We all know that. We have to evaluate the dentures too for fit. If they're not fitting well, it's really best to leave them out for the meal. People who have difficulty swallowing are at higher risk to choke if they have really poor fitting dentures. You can imagine these clanky dentures sitting in there. They're actually blocking a lot of sensation. We use sensation so much to form food and to know where the food is or the liquid is in our mouth. If you've got these huge bulky dentures in there, you're just taking away sensory input from the person. And then they also have a poor ability to clear the food, because that food is getting in and around inside the dentures, and it can be a mess. We also have to make sure, are they being removed? Are they being cleaned? You know, they should be out and soaking at night. And then really evaluating, once you get those dentures unglued, because sometimes they're really glued in there, then really evaluate the gums, you know, clean the gums and evaluate the gums for sores. Something called stomatitis is like sores that can happen underneath the dentures. So yeah, very important. And then chlorhexidine. There are many different mouthwashes out there. Chlorhexidine is one of the ones that's most commonly researched. It's a short-term use, broad-spectrum antimicrobial mouth rinse in different quantities there. And there's quite the debate out there in the literature. It's something that has been found to prevent bacterial biofilm and candida. It can reduce plaque, improve plaque index scores. It can be used to treat gingivitis, candidiasis, that's the thrush, and ulcers. It can treat some antiviral, or has some antiviral properties, like for cold sores. And there is good high quality evidence of randomized control trials using this as a rinse or a gel to help reduce the ventilator acquired pneumonia. And that's really where chlorhexidine has been mostly used, is in the ICU and for ventilator acquired pneumonia. As opposed to, I have this as sort of like the plus side and the minus side, as opposed to this one study down here that had looked at, a very liberal use of chlorhexidine on the regular floors, non-ventilated and non-ICU floors, and they did find some association with an increased risk for death. Other review studies said, a significant increase of mortality was only seen in one of the 11 studies that they reviewed. So there is, a balance that needs to be looked at. It's not something that the speech pathologist will recommend. It's a conversation that the speech pathologist may start with the medical team. Some other negatives of it could be teeth staining, the taste. You also have to make sure that you don't eat right afterwards, that you don't use normal moisturizers for 30 minutes afterwards. There's some rare anaphylactic allergies, and this interesting study too was that it was not superior to the control solution. And that was, you know, as a mouthwash summary here, this study that I just mentioned there, they summarized that meticulous oral cleansing seems to decrease the risk of development of pneumonia, regardless of the content of the solution. This study compared the use of chlorhexidine to usual care, but their usual care was already stellar. It was, they were already using a good, you know, mouthwash solution and brushing teeth. So they didn't find much difference. And what they really noticed was that it was the meticulous oral cleaning, the mechanical oral cleaning that made the difference, regardless of the content of the solution. So if mouthwash is to be utilized for plaque reduction per national guidelines, this is in UK, national guidelines state that mechanical toothbrushing and interdental cleaning, that's the flossing. If we finally get brushing done, then we'll push flossing, right? And you know, these are the preferred methods for effective plaque removal, and that any mouthwash should be used as an adjunct rather than a replacement for brushing. So we'll end here by thinking in a transdisciplinary way, and thank you so much for you know, being here today and thinking in the future how you're going to be communicating, collaborating, and constantly questioning. I want to end with just kind of noting Dr. Madison Mock, just such a great neurocritical care physician out of Colorado, has wonderful critical care research out there. You know, and he pointed out how our understanding of the mechanisms of aspiration pneumonia is just not complete. You know, why exactly are the critically ill people who aspirate more likely to develop pneumonia? It may be due to alterations of oral flora to include more pathogenic gram-negative bacteria, as we said today. So it really highlights the importance of collaborating, you know, with the people that we serve, and, you know, including dentistry with medicine, including industry, ethicists, you know, our Joint Commission surveyors, our lawmakers, you know, to really start changing how things are done in medicine. Just to kind of go over, I have lots of references for you. These are ones recommended by John Ashford, ones from Kendria Garand and colleagues' articles. And then these are all just alphabetized many references for you. The 4-part series that I did on, you know, microorganisms and you know, like the one that I was talking about with the volcano, more blogs, traveling to the desert and comparing the desert biome to oral microbiome too. So if you're missing traveling, just, you know, read those and, and dream up your next trip eventually. And then also I have a chart that can cause, of medications that can cause dry mouth. There's also information on dry mouth in Spanish and English at this spot. And then I will end here to ask for questions and just really, you know, joyfully looking at all these smiles. The smile is so universal, and I just love these pictures. So I will pause now and invite Elizabeth back to see if we have some good questions.
Karen, thank you so much for that wonderful presentation.
Yeah, thank
Incredible.
you. Thank you for, you know, allowing me to go over time and still listening.
Absolutely, we would never cut you off. We have tons of questions. We probably won't get to all of them, but I certainly will send you all of them, and we can put
Yeah.
together a document to share with everyone if that's okay with you.
Sure, sure.
I wanted to start with here, we have a lot of community members here who have swallowing disorders and their loved ones who have asked some really good questions. And the first one is from a caregiver of somebody who has Parkinson's disease, and they take medications to help them control their excessive saliva and excessive drooling. And they're wondering, now that they've watched your presentation, which might cause more bacteria, the excessive saliva pooling or dry mouth from taking the medications to reduce the pooling?
That's such a good question. So yeah, so with Parkinson's, to kind of back up there on it a little bit, There is a hypersalivation or excessive saliva that we observe, and we think that it's partially because of an inattention, a decreased awareness or inattention of the saliva in the mouth. We tend to swallow thousands of times a day with just the quantity of saliva that we have. And with Parkinson's, as you see it with the voice as well, there's, it's sort of an attention issue that not realizing that your voice is diminishing in loudness, and maybe also then not realizing that there's a lot of saliva accumulation, and they're just sort of almost forgetting to swallow. The motor programming is forgetting to swallow as often. The sensory feedback of the need to swallow is not happening as much. So some neurologists recommend like having them chew or suck on some sugar-free gum or suckers to just kind of constantly bring the awareness to be swallowing the saliva. The reason why I say this is that because, if we're not treating the underlying reason within Parkinson's of why this extra saliva is there, then the other option of treating it is with these medications that just dry up the mouth. So, so that's the risky thing. So there's a lot of different medications out there to gently dry the mouth. Some of them are even off-label use, like there's a Levsin, Levsin. It's a stomach ulcer medication, believe it or not, but we use it a lot with people who have MS as well. It's an under-the-tongue sublingual meltable type medication. It's something where you want to make sure that the medications that you're using are gentle enough to maybe give you a little bit of drying without overly drying or without drastically changing the saliva chemistry and the pH of the saliva, because then it's this real balance. So just working with your doctor and even including a pharmacist to try and find a good balance of gently drying, but at the same time then really needing to do really good brushing, good electric toothbrush, good flossing, good mouthwash. Also making sure your mouthwash doesn't have any alcohol in it, because that can really just drastically alter the flora of your mouth. So you're trying to maintain your good oral flora at the same time as trying to manage that saliva. I've worked with people with Parkinson's who it can be so much of a handicap to have so much saliva. Maybe you're working and you look down and it's just starting to pour out, and then you didn't realize it was there. And so there's some evidence saying, if we just kind of work therapy-wise to help increase attention to the mouth and to the saliva and to the swallowing, that could be sort of a behavioral treatment in addition to those medical treatments. So sorry, that was a longer answer than it was a good, complicated question. Go ahead.
Yes, great information. Thank you. I have another one here from a head and neck cancer survivor who experienced a life-threatening aspiration pneumonia several years ago, now has a feeding tube. He, among other people here on the webinar, are asking, what is the best suction and electric toothbrush that you can get in the community, and about how much does it cost?
Yeah, I'm not sure about the costs of, because you'd want to have, I think what they're meaning is like a suction machine for the home. Do you think that's what they mean? So to have a suction machine for the home, and then to be able to get these kits, something like this, that you'd have these connect right up to suction tubing to the machine at home. The actual costs of getting that suction machine at home, I'm not sure of, but that should be covered by insurance. The actual suction machine, it is a piece of durable medical equipment. Your physician should be able to write a letter of medical necessity for that. We also really need to push insurances to cover these products, because these are medically necessary products, and that's what I was having a conversation about prior to this lecture with a woman who is fighting on this for pediatrics as well, that we really need to push that these are needed with the suction at home. And Elizabeth, let me know if I somewhat answered that. I'm not sure the exact prices.
Yes, and you're welcome to email the foundation. We have a list of some devices we have found over the years as well.
That's why you're here. Thank you so much.
I have a couple more questions here if you have time, and then I want to be respectful of your time and let you go. The next question
I can stay
here
as I can stay as long as people need. We've still got a good number of people on the lecture, and I know my lecture was probably longer than usual. So as long as we need, we can try out a little longer.
Awesome, thank you, Karen. The next question here is about medications, and it's from a speech pathologist asking, what are the medications that can cause xerostomia that we should just know off the bat?
Yeah, that's a really good question, and I also have an article. I'm just cruising down through these slides here. This is the one where I mentioned some of the drugs that cause dysphagia. So a lot of these are certainly the antipsychotics. The antipsychotics can cause dysphagia alone, but they can also cause dry mouth that can lead to dysphagia. Majorly the antidepressants are very dry mouth causing. So antidepressants, the antihistamines, certainly like Sudafed and things like that. Even as the prior caller mentioned with their loved one with Parkinson's, even some of the Parkinson's medications can cause dry mouth. So Sinemet can have a side effect of Parkinson's as well. Or, sorry, Sinemet can have a side effect of dry mouth as well. And then of course the diuretics. So a diuretic is when you're taking Lasix or a similar that flushes extra liquid out of your body. So if you are on a diuretic because you're retaining fluid, Lasix is something that certainly is going to cause dry mouth. And so for the speech pathologists who are working especially in acute care, a lot of people coming in with congestive heart failure, for example, might get their Lasix all of a sudden ramped up. So these are just questions that you need to ask the medical team, ask the nurse, oh, I see he's on Lasix. Is that a new amount of Lasix? Is he on a lot more Lasix than he had been on before? And it's like, oh, no wonder his mouth is so dry and he's having increased trouble swallowing that he didn't have at baseline. So, it's such a great question from the speech pathologist because it shows how we need to look at so many different things, and we need to communicate with the medical team in an intelligent way about medications. And so those are just some of the medications that cause dry mouth. There is a big chart in this blog, and that chart breaks down the medications into the ones that cause dry mouth. Okay.
Excellent, thank you. I have another question here about the OHAT and the OCAT. Are those publicly available, and can you use those with children?
I don't believe the OHAT is validated. I'm just cruising back here. I don't believe it's validated with children. So if you take a look at the references, the Chalmers references there, this one, Chalmers, is publicly available. Easy to get the PDFs and everything. I have reference here as well as in my reference list of the cited Chalmers ones. So the OHAT is readily available to use. And then the OCAT that was used at the Beth Israel, there will be information on that in the publication, again, that is in the reference list. I'll just kind of also show you, of course, the Chalmers one here, several studies by Chalmers, and then the Beth Israel Wagner study here in 2016. So those references are there to find those. And I think the OHAT by Chalmers has been around for quite a while, and it is probably the most familiar with nurses out there. Okay.
Yes, and I will send your references and your slides in a post-webinar email. So just in case you didn't have the chance to download the slides during the webinar, we'll make sure that you have those. I'm going to ask one last question here.
Okay.
And this question is from a speech pathologist who works in acute care, and they're wondering if hospitals should involve speech pathologists in the care of patients who are intubated to initiate an oral infection control protocol while the patients are still intubated.
Yeah, it's fabulous. And the speech pathologists that work in acute care should be working, directly with the multidisciplinary team, the nurses, the intensivists in the ICU. And when they did this work at the Beth Israel, it was a broad team that was doing the work, and they created the policy. You have to create a multidisciplinary policy. So the question kind of asked, should the nurses just refer to the speech pathologist when there's an issue of poor oral health? And, certainly we want to be involved in that, and we want to give guidance on, how to ramp up good oral hygiene when somebody is intubated. But we also want the intensivists and the nurses and the people right in the ICU to be taking taking control of this. The speech pathologists might not be there all times of day and the weekends and things like that, where the ICUs need to take charge and have a program of good oral infection control, whether they're intubated or not. And certainly the speech pathologists can help guide the guidelines and the how-tos. The other thing I wanted to mention is that when people are intubated, Martin Brodsky out of Johns Hopkins. Johns Hopkins is a great research to always be looking at. You can even follow them on Twitter. And so Martin Brodsky has been pushing for having speech pathologists work with people who are intubated, and so working with them in oral stimulation, so that's the oral infection control, but also starting to get some movement and some work, because these people are for so long intubated, and it's just a use it or lose it. There's so many days or weeks of them just not feeling or using or actively sensing their oral cavity. So if we're in there a lot early on, that's a sort of a future area in speech pathology in ICUs that could be an interesting area.
Thank you. That's fascinating.
Yeah.
Right. Well, Karen, thank you again so much for your time and for this excellent presentation. It was hard to wade through all the positive feedback in the comments here over in the.
Terrific. Well, you'll have to send that to me. That's terrific.
Yeah, I sure will. I'm going to turn it back over to Ed, and I will steal the screen back from you here.
Okay, great. Well, thank you, everyone.
Thank you.
Karen, I have a question before you go. Do you have a preference between dental floss and dental picks?
Yeah, I'm not a dentist, but I just played one on TV. No, kidding. So it's a great question for your dentist, because I'm sure, like within speech pathology, we want to personalize the treatment to the person. So I'm sure a dentist would have specific recommendations. I know with my teeth, they're so jammed together from so many years of orthodontia that I can't get those little brushes in between there, those tiny little brushes. And I have to use really thin dental floss just to jam it between my teeth. Whereas other people are going to have huge areas and cavities where they're going to want to use those tiny little brushes or different types of floss. So this is another reason why we have to make sure that our people at the hospitals and nursing facilities are getting some kind of attention. I think we really need to start pushing for professional dental hygienists to be coming into rehabs and nursing facilities and having more collaboration at the hospital with dentistry. That's my dream.
Well, I'd like to thank you for an amazing amount of great content. And I saw comments coming through from dozens of people that were just so impressed and thankful for the information that you shared with them this evening. Terrific. Yeah, so thank you for volunteering your time tonight. That's just awesome. And Elizabeth Lipton is the foundation's executive director. She organized this program. So I want to shout out to Elizabeth for all the work she did to make this a seamless experience.
Yes.
And I'd like to thank everyone for attending. If you had a question that wasn't answered, we will try to get an answer back to you within an hour. A survey will be mailed about tonight's webinar, and our next webinar is in May, and it is on the topic of the what, where, how, and why patients can empower themselves by being their own advocate. So in less than 2 months, we'll have another webinar in our webinar series.
Yeah.
So,
And those two speakers, if I may just say, are going to be fabulous. So definitely don't miss this one.
so Karen, thank you again.
Thank you so much.
Yeah, and hopefully see you next year in person at DRS.
DRS in Puerto Rico, we'll be there.
Very good. Signing off, everyone.
Thank you.
Thanks for joining in. Okay. Bye, guys.
Bye-bye.